Hi, my name is Joni Ford, and I will be presenting my journal club presentation in grand rounds on the case for Crohn's disease. And the article that I chose was the effect of cognitive behavioral therapy on clinical disease course in adolescents and young adults with inflammatory bowel disease and subclinical anxiety and/or depression, the results of a randomized trial. For this week, I'm going to be discussing the case of a 19-year-old female who's been diagnosed with Crohn's disease. Her health history includes having had several months of unexplained diarrhea, which led to a diagnosis of Crohn's disease of the terminal ileum. She started Asacol at 1,200 milligrams, and after 3 days of beginning that medication, she developed a fever and was admitted to the hospital for 7 days. She's currently taking prednisone at 60 milligrams per day. She comes into the office with complaints of weight loss, diarrhea, fatigue, anemia, pain, and cachexia. And her goals are just to basically experience less symptoms and to begin gaining weight that she lost. So the question I seek to answer based on the case this week, is would cognitive behavioral therapy be a beneficial recommendation for someone who has Crohn's disease? Um, and I know that that's outside of the scope of nutritionist practice. However, my rationale is that we actually, as nutritionists, do make recommendations for services outside of our offices, and because we know that people with IBS and IBD tend to have higher occurrences of anxiety and depression diagnoses. Um, I was curious about the fact of CBT as being a therapy or potential therapy for people with these types of disorders. So when looking into the research, I did a PubMed search of the keywords Crohn's disease and behavioral therapy with a 5-year filter. I got back 158 results, including 5 clinical trials, 6 case reports, 30 reviews, and 11 observational studies. And I chose to focus on the article entitled Effective Cognitive Behavioral Therapy on Clinical Disease Course in Adolescents and Young Adults with Inflammatory Bowel Disease and Subclinical Anxiety and or Depression, results of a randomized trial. Um, and so this particular paper was cited as a reference in 2 other studies according to Google Scholar. The paper was published in a journal called Inflammatory Bowel Diseases, which supports the mission of the Crohn's and Colitis Foundation by bringing the most impactful and cutting-edge clinical topics and research findings related to inflammatory bowel diseases in clinicians and researchers working in IBD and related fields. The journal is committed to publishing on innovative topics that influence the future of clinical care, treatment, and research. The scope of the journal is diagnosis, treatment, and management of irritable bowel disease. The authors, are from an array of different organizations, but they all tend to either center on pediatrics or gastrointestinal organizations, hospitals, research institutions, colleges, and things of that nature. And I have listed them here for you, along with their respective institutions. So a brief review of what Crohn's disease is. It's one of the irritable bowel diseases that basically is a result of inflammation of the small and or large intestine, and it's accompanied by unpredictable bowel movement, so typically diarrhea that's uncontrollable and unpredictable. And the result of that, a combination of that and the fact that it's a highly inflamed bowel, would definitely lead to lowered nutrient absorption capacity. So people with IBD, and in this case Crohn's disease, typically have problems with nutrient absorption and extreme weight loss that's unable to be controlled. So from the article that I found, the research question that the article attempted to answer was, would CBT promote sustained remission, prolong the time until first relapse, and reduce clinical disease activity and inflammatory markers in patients with IBD compared to those receiving care as the usual? Does it observe the four components of the research question according to PICO? Well, yes, the population is included, which is patients with IBD. The intervention is cognitive behavioral therapy. They are using a control, which is CAU, which stands for care as usual, which basically means that they undergo the same care that they would usually undergo. And the outcome is sustained remission, prolonged time until first relapse, and reduced clinical disease activity, inflammatory markers. The inclusion criteria, the people who were included in this study were all patients who had either ulcerative colitis or Crohn's disease. They were between 10 to 25 years old, and they had all been, they have all granted informed consent or signed informed consent forms. And if they were pediatric patients, then the parents signed them. The exclusion criteria include a parental report of intellectual disability, current treatment for mental health problems, insufficient mastery of the Dutch language, as this took place in the Netherlands, CBT, having had cognitive behavioral therapy in the past year, for at least eight sessions. A diagnosis of selective mutism, bipolar disorder, schizophrenia, autism spectrum disorder, obsessive compulsive disorder, or post-traumatic or acute stress disorder. And if they had participated in another intervention study, then they were excluded. And having been diagnosed with anxiety or depression, they were excluded. So this paper's design was a randomized control trial. The population included 70 participants, 5 of whom were in remission. I must say that this actually did start off with a great deal of participants who were recruited from hospitals by doctors who were treating the patients for either UC or CD. However, after the exclusion criteria was applied and then the intervention was revealed for the people who were selected for the intervention group, many people decided to drop from the study because they found out that it was a psychological intervention. The researchers did mention that as a limitation of their study, and that they also stated that many people are not as open to psychological interventions as opposed to other interventions such as medication or nutrition or other lifestyle factors. Um, Anyway, 68.6% of the study's population was female, 50% were less than 18 years old, and the median age was 18.27. Again, the range was from 10 to 25 years of age. 51% of the participants were diagnosed with Crohn's disease. 81% were of Western ethnicity. 17% had low SES, 36.8 had middle SES, and 45.6 had high SES. And 71% of these participants had anxiety symptoms, 4% had depression symptoms, and 24% had both anxiety and depression symptoms. But again, none of them had been diagnosed with anxiety or depression. The intervention, well, both groups, the intervention group and the control group, received care as usual, which for the sake of this article and this study, care as usual meant that they had a medical appointment with a gastroenterologist every 3 months. The intervention group, though, also received primary and secondary control enhancement therapy, also called Pasquet therapy, which is a cognitive behavioral therapy that was created specifically for people with IBD, IBS, and it was modified to include anxiety treatment because it doesn't have it in there already. And it was also modified when necessary to make it age appropriate for the younger participants. This therapy was performed by licensed psychologists. There were 10 sessions that took place over 12 weeks. After the 12 weeks were over, there was 1 session per month for 3 months after the initial 12 weeks. I didn't write this, but participants were followed for 52 weeks after the intervention was performed. I should also add that 3 additional family sessions were mandatory for children and were voluntary for people who were 18 or over. So that means that potentially people could have gotten a total of 16 sessions, 13 individual and 3 with including their family members. 6 of the 10 sessions over the 12 weeks were face-to-face and 4 were by telephone. So these are the results from the study from after the study was conducted. So after the study was conducted, the researchers gathered the data to determine whether or not there were changes in clinical disease activity after the study, in C-reactive protein after the study, and in fecal calprotectin markers after the study. And as you can see, there were no statistically significant markers in any of those areas after the study was conducted in either the intervention group or the control group. The strength of the study included the fact that the intervention was conducted on both children and adults. Most of the articles that I came across when doing the literature, the search of the literature, either had articles on children or adults, but this one has both, and I suppose that gives it some measure of generalizability that the other ones don't have. Laboratory data was used to measure outcomes, and the reason why I listed this as a strength is because a lot of the other studies that I came across while doing my search of the literature on measures such as cognitive behavioral therapy and mindfulness activities and things of that nature, a lot of the measures were more subjective and kind of dependent on the person or maybe even the culture or whatever. But in this particular case, actual laboratory measures were used given more objective results. And the patients received 6 months of treatment, which is awesome for something such as cognitive behavioral therapy. I think it's a good amount of time to be able to tell whether or not the therapy was useful in most circumstances. So the limitations of the study include the fact that the population was drastically reduced in the beginning. One of the things that crossed my eye was in the summary when I chose this article was the fact that I think it was like 570. I'm not looking at the article right now while I'm talking, but there was a good number of participants in the very beginning, and that made me excited to read it. But then when I read it, the fact that it was kind of dwindled down so much, I was a little disappointed. And although 70 people is still a relatively good amount of people, it was discouraging, not just because the number dwindled down and so it wouldn't be as strong of a result as 570, but also for the fact that it just kind of gives you an idea of how low of a value we as, I guess, a human society places on things like cognitive behavioral therapy, mindfulness, meditation, and things of that nature. So, but that was a limitation. Also, the fact that there are many potential confounding variables and factors. So while there was a lot of exclusion criteria, which I think made the study fair, there's still the idea that, we don't know what medications the participants were taking. We don't know if they were eating a certain diet or not. We don't know if they had physical activity or not. We don't know if they were spiritual beings or not. And so, it's really difficult. And I think a good question to ask would have been, like a benchmark question would have been, how do you feel about cognitive behavioral therapy? Because, we also know that CBT works best when you actually want it and value it. People who are doing it because of, let's say, a legal mandate or something like that are less likely to take it seriously or even apply any of the techniques that they learned during the therapy. So, things like that are all things that I would like to know in order to really get a good glimpse of the people and to know if this is, if the results are actually legitimate or not. And then it's difficult to apply the results of this study across demographics, specifically ethnicity, seeing as though the study was largely Western ethnicity. Most of the people in this study were Dutch, and so we don't know if we can apply that across cultures. So to put it in clinical context, would CBT promote sustained remission, prolong the time until first relapse, and reduce clinical disease activity and inflammatory markers in patients with IBD compared to those receiving care as usual? Well, according to this study, the answer is probably going to be no. And it's a maybe for pediatric patients. And even though, I did mention that none of the results were statistically significant, they actually did combine pediatric and adult data, but in the body of the article, they did separate the pediatric data, and the pediatric laboratory markers did improve in a measure that was statistically significant for calprotectin. So in that case, it may be beneficial for pediatric patients, but according to this data, not for adults. And then my original question, as far as the case is concerned, would this be a beneficial recommendation for outside referral for our client who has irritable bowel disease? And, if I go specifically by this data, I would have to say no. However, given the fact that we do know that anxiety and depression is markedly increased in people with irritable bowel disease, I would probably still continue to make the recommendation despite the findings from this article, even if it doesn't help solely, not, given any other factors such as medication or nutrition or lifestyle changes. It will definitely help with stress and anxiety and depression management. And then, of course, we know over time that can help with overall health. So even if it doesn't directly influence markers for IBD, it can definitely help with the patient's overall state of mind and well-being. And to me, the fact that it will help with their well-being is worth making an outside recommendation for it if the client shows signs of anxiety or depression. And here are the references I used, and I also included the reference that noted that basically people with IBD have really high or higher anxiety and depression levels than other groups of people.